Thank you very much. First of all, I would like to thank the PSNM Executive Council and our President for giving me this opportunity to present my talk and also giving an opportunity to meet my respected seniors and my wonderful students. Okay, I start my presentation. Now it's about the new radioisotopes on Theranostic, rather Pakistan's Theranostic. So I would like to talk about the new radioisotopes coming up in the world and what radioisotopes are being introduced, will be introduced in the future in Pakistan. Okay. So I think nuclear medicine is experiencing a very exciting era, and it is because of the Theranostic. And NM has now an opportunity to become an established partner in the therapy of cancer. Though Theranostic is a form of precision oncology, a real personalized medicine. And our ability to see what we treat and see what we treat and treat what we see is unmatched in any field of medicine. And Theranostic, the beginning is, not a new concept. And it has been there since 1930s and 40s. And it has a very humble beginning when first study was published on the role of radioiodine in CA thyroid. And it's because of this person, the Cyril Hertz, who is considered as the father of Theranostic. And he was actually chief of thyroid clinic at Massachusetts General Hospital, who introduced the concept of radioactive iodine Theranostic and first brought radioiodine from bench to bedside. I will not say much because I'm very glad to see his daughter in the audience, and she will be telling more about his illustrious father. He was a visionary person, and he said that my new research project is in cancer of thyroid, which I believe holds the key to larger problem of cancer in general, and how true he was. As the time went by, the procedure evolved as well. The sodium iodide has two different iodine isotopes, iodine 123 and 124 and 131, has become an important method for thyroid cancer monitoring and treatment. Now, over the last 80 decades, there have been a lot of advances in radiochemistry, enabling us to target more tumors using the same principle. And coming to timeline, Theranostic, the first line is the year when the first human study was done, or it was the publication was done, and this is when that radioisotope was approved. And you can see there has been a gap of 10 to 15 years. But however, in the future, we have to be very fast to achieve this goal. Coming to the most important theranostic agents, lutetium dotatate and lutetium PSMA, which were approved recently. And these are actually the two most important trials, the NETTER-1, which gave us the lutetium dotatate, and the VISION trial giving us the lutetium PSMA, which are being used routinely in the routine clinical practices. So whole body images acquired after lutetium dotatate, and you can see there is a remarkable recovery, remarkable decrease in the metastatic disease. However, still after 4th cycle, there is some disease left. So my question is, what next? What next? And I think most of you sitting here, the nuclear physicians, have seen this wonderful image, which was the image by the Michael Hoffman from Peter MacCallum Hospital in Australia, and which was the image of the year 2018. And this was the presentation which actually changed the perception of the Theranostics, and you can see a dramatic change in the decrease in the disease burden, as well as dramatic decrease in the PSNM values. However, I call this good one, but there are bad and ugly ones also, and in which you can see that even after the therapy, the disease burden increased and increase in the PSA level. So my again question, what next? So I will be telling in the next slides what should be done. And you can see most of the studies and most of the trials which were done and which are going to be done in the future employ lutetium-177 because this is the most important, most, you can see, competent type theranostic therapeutic agent available. However, these are the data from the perspective trial using lutetium PSMA, which was done by the Australian group in this first study. and this is a USA one. And you can see that in this Australian group, there was only 57% of the men, they had their PSA value down. And in this randomized, in this UCLA study, only there was a drop in PSA in only 37% of the patients. The good news was that there was a considerable, they had more years to live. So there was a survival, their benefit was there. And then come the Vision phase 3 trial, and which the standard of care was compared with the standard of care and lutetium PSMA, and you can see there was a survival benefit of few months. So we need to, this shows that we need to continue our efforts to improve the therapies, and fortunately, we have a number of methods to do that, and most interesting is the use of different radioisotopes. So we have different radioisotopes, beta emitter, alpha, and Auger. And you can see. So this means the radiation, the Auger, and especially the newcomer, because it is extremely short range, yields the high linear energy transfer, which makes Auger electrons attractive for radiation treatment of cancer, especially if they are emitted in the close proximity of sensitive targets such as DNA molecules. And so we have a wide variety of the radioisotopes to play with, and the beta emitter, the alpha, and the Auger. So I will only concentrate on the above line, because there have been a lot of studies done with calcium, scandium, and thorium, but somehow they are not made into the clinics generally. Now coming to terbium, so I have a very little time, so I'll go fast. The terbium is called a new Swiss Army knife for nuclear medicine. Maybe because they were developed, the terbium isotopes are developed in the PSI and the Sun, which are located in the Switzerland. And it's unique, the terbium isotopes are unique that it represents radioisotopes for all 4 modalities in nuclear medicine. We have a beta emitter, we have a alpha emitter, terbium 152, a beta plus emitter, terbium 155, a gamma emitter, and terbium 161, the beta minus and Auger emitter. So I will take individual one by one. Now coming to the terbium 149 based alpha therapy. And although alpha emitter, okay, you can see that a lot of preclinical studies have been done, and you can see increased concentration in the tumor. And because of the increased half-life, it has a large half-life, so you can see, we can image at different time points. And you must be wondering, if it's a alpha emitter, then we still can take the image, because it also emits a beat positron. So this is called the alpha PET. However, the only problem is that it is difficult in production and chemical separation, and of course the presence of long-lived daughters and high recoil energy, and which complicates dosimetry and whole body radiation dose. Now coming to the second one, the terbium 152, this is a PET tracer with long half-life, and this is an advantage because we can again image at different time points. And one study done by Baum et al. Is also done in humans. Again, the problem is the production of terbium 152. It is very challenging. Now, terbium 155 could be produced in a cyclotron with potentially very high yields. And as a diagnostic match, terbium 155 may be of particular value for visualization and staging of malignancy and for dosimetry calculation. It's a good diagnostic counterpart of terbium 149, 161, and actinium-225. Now, the most important one, the terbium 161, and it is considered as a new lutetium-177. It can be produced, it is basically a beta minus and Auger electron emitter. It is a very interesting radionuclide because it can be an alternative to lutetium-177, and its production is analogous to lutetium production with the help of by the radiation of enriched gadolinium-161, and a large amount of terbium-161 can be produced, non-carrier rate can be produced in reactor. And it has all the benefits just like the lutetium. I'm not going to detail in one. The most important one is because of high lead conversion and Auger electron, it delivers 3 times higher absorbed dose to the tumor. So it is much better than the lutetium. And most of the preclinical studies have shown that not only it's a good uptake in the tumor, but it has also shown that there is a decrease in the growth of the tumor in the animal model and increase survival of the mice, the animals. You can see that this is where even the DOTA, it has been labeled with the PSMA and the DOTA. Okay, first in human application of terbium was done again by the Richard Baum, and you can see that not only the biodistribution but uptake in the skeletal mets here. Although it's the gamma emission is of low energy, but still you can see we can get very reasonable images. And another study was done by the Akram and Jordan using terbium-161, and he also got very good results. So again, the question arises whether it is superior to the, it has the superior therapeutic efficiency of terbium-161 over lutetium. Indeed, there have been many studies which actually compare the terbium and the lutetium-177, and the data speaks of themselves that it is much better, it is much superior, and there is increased efficacy of terbium-161. And already number of trials, human trials, are in progress in Switzerland, of course in Australia, the Hoffman is doing, and in Germany. Now coming to target alpha therapy, we all know that alpha particles are 100 times more potent because of their high lead. And they have been great interest in employing the alpha emitters in the therapeutics. And there are few alpha emitters, but most important, and I'm talking about the actinium-225 and lead-212. So actinium-225 has been considered a potential candidate for use in cancer therapy with high energy 4 alpha and 2 beta minus emission. As a therapeutic has been limited by, the toxicity and the availability of the chelating agents. Still, so now coming back to my previous scans, which I called bad and ugly, and you can see here one of the example, that after the 2 cycles of therapy with lutetium-177, there is still quite a large burden of the disease in the patients. So the question there was what next? So now we have a question we can employ, and this is an example where actinium-225 PSMA cycle, or 2 cycles were given, and you can see the disease disappearing. Same here, another patient with and this same patient another patient with 3 cycles of actinium-225 PSMA therapy, and you can see the disease vanishing. And actinium PSMA trials are being conducted by the South African group, by Satighe group, and they clearly show the excellent results, the excellent survival, and you can see that almost 100% of the patients which are being, we have a drop of PSA.
Dr. Shabana, sorry to interrupt you, this last 2 minutes.
5 minutes, please. So lead-212, and another very promising alpha emitter is lead-212, and the beauty of it is that it can be produced in generators. For the lead, there are 2 methods. Generators contain the radium source adsorbed resin, and another one a bottle or vial containing the radium source adsorbed on glass wool, and from there the radon-2 emanates, and from the source and decays into lead-212, which can be collected by using HCl. So now since I have very little time, so I'll rush through my slides. So now coming to new radioisotopes on Pakistan Theranostic horizon. So what we will be getting, we will seeing we'll be getting actinium-225, lead-212, terbium-161, and terbium-155. So how it is through the Pakistan and CERN collaboration. We are collaborating with the CERN, the Medicis, which is actually, we are the associate member of the CERN, and the Medicis actually is a facility contributes to medical research by producing novel radioisotopes. And we will be getting these radioisotopes through there. And they not only supply the radioisotope, they are not producing, they are not on the production facility, but they are actually they're transferring their expertise and knowledge also. So they are producing radion-225 in a sol day, and then which is being used for the lead generators. And since 2021, we have already got 3 shipments of actinium-225 from the Medicis, and basically these were actually processed, and they were processed at Equinstic. One shipment was dispatched to INMOL for labeling for stability study, and in future, inshallah, we'll be getting shipment of human-grade actinium-225 for clinical trials in Pakistan. And in future, we will be producing indigenous production of 2 to 5 through radium. We have some radium reserves with us. And similarly with the generator. In future, lead generator shipments to Pakistan, they have promised to do that. And moreover, one of our scientists, Princeton scientists, is working at CERN and working on this generator. So he will bring his expertise to produce indigenous development or for the indigenous development of the generator. And terbium-161, we can produce it very easily in par 1 and par 3. And unlike lutetium-177, it is more easy to produce, more easy to separate, and for which we have already purchased gadolinium-161, the target. And the only problem was with the resins, which again, CERN people have promised to supply these resins for the separation and process. And we will soon be getting shipment of these resins along with the terbium-155. So with all these new radios, enjoy the ride. The new wave is here. Now coming to Theranostic in Pakistan, the past. Then I will take you to a slide presented by Dr. Shazia, our president, in 2014 in Nathia Gali. And just 2 minutes, it's very interesting. Actually, at that time, she said that at time only radioisotope, radioiodine was being used for this. And very few centers were doing MIBG, P32, radiation cyanidectomy at that time in 2040. Now, come 2023, we have what we are doing, the UNMOL is doing the lutetium therapy routinely, and we have now the indigenous production of lutetium-177 with reasonable specific activity. And we are the Princeton people are providing the DOTA kits, the PSMA kits, and high nictate kits. So, and this has been actually used in different patients in Kiran, in UNMOL, in NUM. So future will be getting, of course, these important radioisotopes. So future of nuclear medicine theranostic in Pakistan is not that bleak, and it's quite bright because we are getting new radioisotopes. And only thing is that we should expand clinical trials network through nuclear medicine centers all over the country. We should also train our workforce and promote nuclear medicine as true precision medicine and create competent Theranostic center. So another slide I'll take, I have borrowed from Dr. Shazia. She actually, this was slide from his presentation, and she said, Pakistan ka kaum ka kya banega? My apologies with the foreign participants. So Dr. Shazia, Pakistan kaum ka kuch na kuch ban jayenge as long as we are zinda kaum. and we come out of our comfort zone. And this is one of the my favorite saying, which I also tell my students, they come out of your comfort zone. If you are not uncomfortable every day, we are not growing. Thank you very much.